Initially, the first thing I would like to talk about is not to go and to rush about the lecture, but let me just give you a few tips around about the MRCP exams in general. MRCP is a membership of the Royal College of Physicians, which is a diploma that will enable you to be certified in internal medicine. A lot of benefits you will get from taking this diploma. The first and the most important one is registration in GMC, and this will make you eligible to work in UK or Ireland. The other benefit, many of you, as I know, they are working in Gulf countries, and many countries, they recognize the MRCP diploma, and then with additional experience, you will be qualified as a specialist and sometimes even consultant. So this is also one of the benefits. And the most important over all of them, you know that when you master the medicine and you pass the exams with great scores and with deep concept, the most important thing is the knowledge that you will gather from this diploma, either through the theoretical part in MRCP Part 1 and Part 2, or even the clinical part in the basis exam. All of them, they will give you a very solid approach to deal with the usual cases every day in our life. Well, the second point we are going to talk about is the difficulties faced by many candidates while they are preparing for the MRCP. If I'm asking you, and let me tell you that I know that all of you are muted now, because sometimes the microphone, especially in the introduction of the lecture, they might be open, and sometimes a lot of noises. So all of you are muted, but later on, while we will open the questions and everyone can ask what he needs. Again, what are the difficulties faced by candidates? If we look for the website, we will find that the pass rate, let me just write, sorry. We will find that the pass rate for MRCP Part 1 is about 40% for overseas. I think this is a low pass rate, or when even compared with USMLE exams, which are more tough. But usually candidates going to take USMLE exams, they take a long time for preparation. Most of them, they are well prepared before going to the exam, as there are a lot of competitions, and they have to get a high score to compete on the match. While the MRCP, many of the doctors, they are already graduated and they are working every day 8 hours, and they are just looking for the upcoming exam. It might be after 3 months. I will register for the exam. I will rush to the exam. So this sometimes, unfortunately, will give us a bad result. Okay. So the pass rate is 40%. I think it's not a good pass rate. So if you take the exam, if 100 take the exam, 40 will pass. It's very low. So why 4? According to my experiences and other experiences, I think that the most important cause of this very low pass rate is the method of reading, how we read for MRCP. I'm quite sure that if I ask you how you prepare for the MRCP, either you pass or failed. Most of you, you will say that we read from notes and notes, step up to MRCP, or even only notes. Okay. Sometimes some candidates, they are even going to the Davidson, Comar, and so on. I think all of us, we agreed that Davidson and Comar, they are not suitable for going for the exam, but they are suitable for just renovating your memory and so on. Okay, so what about the notes and note, step up, or only note? They are not books that are suitable for reading from the concept. You know that all of them, They are just collection of answers from the question banks, either past test, either past medicine or on exam. Doctors who read those, who wrote those books, they just collect the notes. For example, if we open the cardiology chapter in Step Up to MRCP, the first topic is long QT syndrome. Then you go for ischemic heart disease, part of it. Then you go for pericardial, again for arrhythmias. This is a flight of ideas. Okay, even the same thing is applied to the other books. The flight of ideas will not give you an organized approach. And if we look for the MRCP part 1, if we are talking about the part 1, this is an exam of the concept and interpretation. It's not just about memorization. Okay, so this is the most important point, I think, that affect the preparation. Sometimes we, as a group, we teach or we read together. We just open the books, we read, but a lot of concepts, they are missed, and we don't know what's the concept. I think this is the most important difficulties faced by many of the candidates. The other thing that those books, even they are preparing you for part 1 and part 2 at the same time. And many doctors who are planning to take part 1, they are they read in depth the questions related to part 2 or even the clinical guidelines. Okay, many of the doctors we know, they are very good on the guidelines. They memorize them, they know them very good. If you ask them the first line, second line, third line, but even they go for the exam, they failed. Okay, because the exam is not about the detailed guideline, it's not the stuff of the guideline. The exam is about the basic concept and the interpretation of the diseases, even sometimes in a simple pathological terms. Okay, so you have to know what you are going to be asked about, and then you have to start your reading, and then you have to go for the exam. And I think, as according to the experiences I mentioned before, many doctors we know, either we taught them or not. I think this is the most important difficulties they faced. Okay, how to solve? If you read alone, to solve this, you go for cardiology. Don't start with long QT syndrome. Don't start with it. You have to start with the arrhythmia from the start. Don't start from arrhythmia from the start. Oh, what is this? I mean that you have to start with basic physiology of the action potential of the heart. How to connect the action potential of the heart with the ECG. Then go for arrhythmias. While you are reading arrhythmias, you will find long QT. You will understand very well long QT. You will know that the QT itself is a reflection of the repolarization, which is the efflux of potassium out of the cells. Then you will know that many things that affect the potassium efflux that will lead to long QT syndromes, and how does long QT syndrome will affect the heart, and how they might causes, for example, torsade pois or torsade de pointy, Aron-T phenomena. A lot of issues, you will never understand them if you don't know the basic concept. Okay, so this is the first point. What we did in our courses since 2016, I think this is the fifth year since starting our courses. The most important thing I told my student, I'm not teaching MRCP courses because I took MRCP. MRCP is taken by many doctors, okay? But I teach MRCP because I have USMLE, and I started these courses during the experience I faced. What is the experience? I started my postgraduate career by taking USMLE exams, and due to some stuff, I decided to go for USMLE, sorry, for MRCP exams after taking the USMLE. You know that USMLE is about step 1, step 2, many basic concepts, pathology, anatomy, physiology, pharmacology, blah, blah. When I started to prepare for part 1, it just take 2 months. Okay, with about 3 to 4 hours per day, and I passed with a high grade. Okay. My colleagues who are preparing for just MRCP, they started the preparation 6 months prior to the exams. Unfortunately, many of them, they failed the exam. In spite of reading for more than 8 hours per day, okay? So it is not about how many hours, it's about the approach. I found that most of the candidates took the MRCP exam, they are just go for the notes and rush to the materials and read without understanding of the concept. So what I did in my courses, I bring all the concept together. I will put them with just a one in a one topic. I will start it to for example, to teach or to learn to teach, for example, arrhythmias. We will start with basic physiology, action potential of the heart, ECG. Then we will go to classify arrhythmias as brady or tachy, and then a lot of this. So the linking of the physiological and the basic concept to the clinical materials is very important and vital to pass the exam. Okay. So this is just an overview about the idea of the courses, and today, inshallah, we will start our first lecture. The other lecture of the courses and the details of the courses, they will be announced later on the group, and I will tell you about the phone number you have to contact it after the lecture. Okay, this lecture will give you an example of the method and the details of the explanation. Today, inshallah, we will go through nephrology. If we are going to talk about nephrology, we have many topics that should be understood very well, okay? We will define the chapter into many points. The first of them is basic physiology. Okay? Basic physiology of the kidney is very important to understand the clinical. We don't go through the basic physiology in details. We just take the point that are clinically relevant. Okay, just a minute, sorry. Okay, the first thing is the basic physiology. The second thing is approach to RFT. It's very important to know what do we mean by creatinine, urea, cystatin, GFR, and so on. We have to understand them very well, and then we go for renal failure. Okay, so renal failure, either acute or chronic. Glomerulonephritis. Glomerulonephritis, they are a group of diseases that are clinically presented as nephrotic or nephritic. The glomerulonephritis diagnosis as minimal chain membranes, all of them, they are pathological diagnoses, okay? After glomerulonephritis, hypertension. Hypertension is related to cardiovascular and renal, okay? Then we have cystic kidney diseases. After cystic kidney disease, we have miscellaneous. Those are the major topics that will be discussed in nephrology. So let us start, inshallah, with basic physiology of the kidney. Okay, we have a note that we will send for you just after the lecture, but I prefer to write on this dashboard to make you more attentive to the lecture. It's better to go through the notes and read. We'll go to the notes after finishing our initial overview, our initial talk, and so on. The functional unit of the kidney is the nephron. The function of the nephron is the function of the kidney. So what is the anatomical picture of the nephron is very important. If we are looking for the kidney is receiving 25% of the cardiac output. So it's very sensitive to increase or decrease of the cardiac output. We have an artery going inside the kidney, vein outside the kidney. Artery is going to the kidney. Kidney is divided into two major parts. Cortex, which is the most superficial, medulla, which is the deepest. It's very important to know that 90% of the blood supply is going to the cortex, while 10% is going to the medulla. Do you think this is clinically significant? Yes, it's very significant, because in medicine, it's very common to see in our CP exam what is called renal papillary necrosis. Papillary necrosis is a sloughing of the papilla, which is of the most deepest part of the medulla that is going to the uterus. This area is very sensitive to ischemia. So if you have necrosis in your kidney due to ischemia, due to whatever cause, sickle cell, diabetes, whatsoever, the first area will be affected is the papillary area, because medulla is just receiving 10%. The papilla is the least one receiving the blood supply from the circulation. Okay, let us move on. So 90% in the cortex and 10% of the medulla. Now we are in the cortex. This is the medulla and this is the cortex. Okay. If we are talking about the cortex, the blood supply is coming through an arteriole called the afferent. This is the afferent. The afferent will come to the glomerulus. Glomerulus is the primary unit of the function, that the most important function of the kidney is taking is occurring here, which is the filtration. Okay, I'm sorry for my bad skills of drawing, but we are just trying to make it easier. Okay, so the afferent is the artery that the blood supply is coming from. Then the blood supply is coming to the glomerulus. What we find in the glomerulus? In the glomerulus, we find the basement membrane, which is the most important structure of the glomerulus. What happens in the basement membrane? In the basement membrane, what happens is the filtration. Filtration means part of the fluid here, which is actually a blood, will cross into the other part. Okay, so blood coming through the afferent, part of it is filtrated. And the normal rate for this filtration is 125 ml per minute. Okay, this is the normal rate for the filtration is 125 ml per minute. So if the filtration is 60 ml per minute, this is renal failure. It might be renal failure. 30 ml per minute, this is renal failure. 15 minutes, this is end-stage renal failure. So we are talking about the kidney disease, either acute or chronic. So we are talking about the filtration. It is all about the GFR, the glomerular filtration rate that happens in this basement membrane. Part of the blood will get out and is not filtrated through this basement membrane, and they will get out into the efferent. Efferent veins? No, efferent arterioles. Physiologists say this is an arterioles because many causes. One of them that this is still oxygenated blood. Okay. The second theory physiologists say is this arteriole has the vasoconstriction abilities, which is very important when we will talk about the ACE inhibitors and ARBs and the role in diabetes, and this will be mentioned later, inshallah. So we call it efferent arterioles, not veins. Okay. So here the filtration occurred in this part of the kidney. Okay, let us start to move from here. Anything affect this basement membrane, so it might affect the filtration. So glomerulonephritis is one of the causes of chronic kidney disease. Anything affect the delivery of the blood to this area, which means this will affect the filtration. This will lead to low GFR. So anything will decrease the blood delivery to this area will lead to renal failure, and this is the concept of the pre-renal renal failure. Hypotension, hypovolemia, even hypertension, which lead to stiffness of the vessels. Okay, this will affect the perfusion to the kidney and is one of the important causes of chronic kidney disease. So the filtration will occur through the basement membrane. We call this area is Bowman space. Okay, once filtration is happening, so let us go to the tubules. If there is anything unclear, you can just message. Okay, it's better than using the microphone now. We will open the questions later. Okay. Okay. So filtration started now, and the blood is coming from the Bowman space to the tubule. We call those tubules proximal because they are the proximal one to the glomerulus. This is the proximal convoluted tubule, which is still within the cortex. In the proximal convoluted tubule, what do we have? And what are the functions that are done in this area? In the proximal convoluted tubules, many solute they are absorbed here. We are talking about sodium, we are talking about glucose, amino acid, bicarb, urea, many things. Many solute they are absorbed in the proximal convoluted tubules. So we are not going to talk in details in physiology, but let me just review the most important clinically applied concept in this area in the proximal convoluted tubule. The first one is the glucose. Glucose is absorbed in the proximal convoluted tubule through transporters. Those transporters have maximum capacity. They can absorb glucose until the level in the blood is 180. If the level of the glucose in the blood exceed 180, so the transporters will be saturated and the glucose will get out into the urine, and this is glucose urea, as you know. The second thing, that glucose is not absorbed. If you are looking for the cell, glucose is not absorbed alone. Glucose is absorbed with sodium. So one of the very important question that is very common to be seen on MRCP exam and related to this area is a class of anti-diabetic drugs, canagliflozin. What is the mechanism of action of canagliflozin and brothers gliflozin family? Gliflozin family, they are inhibiting the absorption of the sodium of the glucose in the kidney. We know in physiology that glucose is related with sodium in absorption. So if you block this, so glucose will get out, sodium will get out. What's the benefit you will get? That you will decrease the level of the reabsorbed glucose, and then you will decrease the level of the glucose in the blood. So the end result is decreasing the blood glucose. I think this is a very good for diabetic patient. The second thing is loss of sodium. Loss of sodium is vital for patient with heart failure. So in MRCP, you will have a question like this. Okay, what's the question? The question, we have diabetic patient with heart failure. What is the best drug? The best drug is gliflozin families, okay, because you will lose the sodium even out of the, you will lose the sodium in addition to the glucose. So this is two benefits. I think they are very good. The second thing here that happen is absorption of the urea. Okay, we are going to talk about urea, inshallah, in the next part of this lecture. And I will talk more about the absorption of urea and what do we mean by urea creatinine ratio, which is very important in diagnosis acute renal failure. Okay. amino acids, a lot of amino acids. No more details now. While we are going in another topics, we will come back sometimes for what is clinically relevant. So here is the site of absorption. The fluid is coming below. This is called loop of Henle. This is the descending part by the black, the descending part, and this is the ascending part. In the descending part of the loop of Henle, there will be an absorption of water, just water. Okay, if the water is absorbed, so the solute will be very concentrated here. Why for is very concentrated? Because all the water is absorbed. Okay, while we are coming up in the thick ascending loop of Henle, we are going to the cortex again. In the cortex, the osmolarity should be normal. Okay, so how to solve this? We have to absorb the solute again before going to the cortex. Initially, we absorb the water. Here we have to absorb the solute to make it neutral. Okay, so how to absorb the solutes? Here in the ascending limb of Henle, we have one of the very important channels called sodium potassium 2-chloride channels, in which the absorption of sodium and potassium and chloride occurring here. Okay, after the absorption of sodium, potassium, and chloride, so most of the solute are absorbed. We will come back to the cortex as neutral or EU. Okay, EU, I mean the same concentration of water compared to solutes. Here in the distal convoluted tubules, we have a very important channels in which there is an absorption of the sodium and chloride. Let us just come back for the sodium potassium 2-chloride and talk about the clinical significant diseases or things that might happen here. The first thing is the action of the drug. One of the very important drugs that block this is, it is working in the loop, so they call it loop diuretic. Loop diuretics like furosemide, torzamide, ethacrynic acid. Ethacrynic is very important. You know why for? Because furosemide, torzamide, they are sulfur drugs. Sometimes we are obligated to give furosemide for a patient with overloaded acute heart failure, for example, but the patient has an allergy to sulfur component in general. If you give furosemide, you might kill the patient. So you have to give another class of loop diuretic, which is called ethacrynic acid. This is pharmacology question. Okay, so the action of the loop diuretic by blocking the sodium potassium 2-chloride, if you block the absorption, so most of them, they will go to the cortex. Oh, so now the fluid is hyperconcentrated. The cortex will obligate it to move the water into the tubules to make it neutral. We need it neutral, even by bringing water inside. Okay, so the water will get out of your vasculature to the tubules and then to the urine. So this is the very nice diuretic effect we found with using furosemide or other loop diuretics. Okay, what is the other clinically important thing we are going to talk? If we are going in the lectures and talking about furosemide, for example, we will go to talk about the side effect, why for we have hypocalcemia, why for we have high blah blah blah. All those details, they are later. Okay, so here we have a channel which are called sodium chloride. The function of this channel is the absorption of the sodium and chloride. And if we have a drug that inhibit the absorption of the sodium and chloride, this will lead to more sodium and chloride in the lumen, so more water will move on, so diuretic action. And this is the action of the thiazide, like hydrochlorothiazide, bendromoflumethiazide, metolazone is also one of the thiazide. All of them, they are working in the sodium chloride channel. They inhibit the absorption of the sodium chloride in the distal convoluted tubules. We have very important diseases working in the loop and the sodium chloride in the distal. In the sodium chloride, we have a disease is very common to be seen on the exam, which is Bartter syndrome. We don't like to go for the exam like this, Bartter syndrome, hypokalemia, blah, blah. No. We have to understand what is Bartter. Bartter is a genetic defect in this channel, sodium potassium 2 chloride. Bartter syndrome, patient with Bartter syndrome usually looks like patient taking loop diuretic. Usually they have hypotension, hyponatremia, hypokalemia, maybe potassium sometimes is normal. Usually they have poor growth because of this electrolyte imbalance and so on. So this is Bartter syndrome, is a defect in the sodium potassium 2 chloride. So sodium chloride channel in the distal convoluted, this is defective in Gittelman syndrome. So Gittelman syndrome is something like patient who is taking thiazide diuretics. In addition to the hypomagnesemia we see, when we are talking about the Gittelman or Bartter in endocrine, we will go in details of those diseases and how the question looks like, but I just give you the overview, okay? Here is the end of the distal convoluted tubules, and here is the collecting ducts. Collecting duct is emerging together to form the initial part of the ureter, and then the ureter and then the urine will get outside, okay? In the collecting ducts, we have a very important thing. Here, at the end of the distal convoluted tubules, is the action of the aldosterone. Aldosterone will move us to the second part of this basic physiology, which is the renin-angiotensin aldosterone system. Let us just write here. What is renin-angiotensin aldosterone system, or the RAS system? Is very important, is a very high yield. So we will go to talk about because it is it takes time. So let us just talk about what happens also in the collecting duct is the action of the ADH. From where we have the ADH. ADH is released from the posterior pituitary in response to increase of the osmolarity. If you don't drink for 1 to 2 days, ADH will be released, and ADH will work in the collecting duct. It will open the channel called aquaporins. Aqua means water, purin means channels, okay? Aquaporins will open and the absorption of water will occur. So the effect of the ADH on collecting tubules reabsorb the water in a patient when the osmolarity is exceeding the normal. This means that the patient is dehydrated, so we have to retain the water. Any abnormality in this, we might have SIADA, syndrome of inappropriate ADH secretion, a lot of ADH, so more retaining of water. If the patient has SIADA, do you think that he will come to you and complain that, doctor, I have a lot of water in my body? No. Usually they are not overloaded because something called aldosterone escape mechanism, which is in physiology. I will not go for it now. This might be discussed later. But they will present with dilutional hyponatremia, which might be fatal in some condition. On the other hand, if you don't have ADH or the ADH is not working in the kidney, okay, so no absorption of water, so no water in your body, so your blood will be concentrated and you will get a hypernatremia, which also might be fatal, and this is diabetes insipidus, okay? So let us go for the renin-angiotensin aldosterone system. In response to hypovolemia, for example, accident or blood loss due to any cause or diarrhea, or hypotension, or hyponatremia, or sympathetic stimulation through the beta-1. All of them, they will stimulate the release of renin. Renin is released from juxtaglomerular apparatus. Juxtaglomerular apparatus is a collection of cells in the kidney, macula densa, and so on. So the renin will be released. When the renin is released, it will convert angiotensinogen to angiotensin 1. Okay, angiotensinogen will be converted to angiotensin 1 under the effect of renin. Angiotensin 1 will be converted to angiotensin 2 by an enzyme called angiotensin converting enzyme. This is a very nice enzyme, converting angiotensin 1 to angiotensin 2. Let me tell you something, that angiotensin converting enzyme, its function is not just to convert angiotensin 1 to angiotensin 2. It has another function. What is it? The other function is the breakdown of the bradykinin. This is why if we give ACE inhibitors, the good thing, we don't have angiotensin 2 and it is a physiological complication, but at the same time, we also inhibit the breakdown of the bradykinin, which will lead to accumulation of the bradykinin and sometimes angioedema in a susceptible patient, or cough, which is common, I think, that might be a common side effect of ACE inhibitor, and we need to switch the patient to angiotensin receptor blockers to don't play with this enzyme. Okay, so angiotensin converting enzyme is responsible for conversion of angiotensin 1 to angiotensin 2. So what is the function of the angiotensin 2 and how this angiotensin 2 will correct the volume, the blood pressure, the sodium, blah, blah, blah. Okay, angiotensin 2 has 4 major functions. The first one is vasoconstriction. The vasoconstriction through the action of the V1 receptor on the blood vessels. Okay. So the first function is vasoconstriction on the blood vessels. In systemic blood pressure and systemic circulation, it causes vasoconstriction, so it will increase the blood pressure. In the kidney, it has a very important role that related to the use of ACE. What is the important rule? Let us go to discuss about it now. This is the afferent, this is the efferent, this is the basement membrane. Assume that we have a patient now. The ambulance is called by someone who is bleeding after RTA, blood loss. So there is a blood loss now. So the amount of the volume coming to the kidney through the afferent is decreasing. In physiology, subhanallah, yani, our human body is a very important thing to maintain the GFR. As we know that if the blood delivering to the glomerulus here is decreasing, so the GFR will decrease immediately. This will lead to renal failure within seconds to minutes. To preserve the function of the kidney, angiotensin 2 is coming and do constriction here in the efferent part. Okay, so the patient is bleeding now, angiotensin 2 is coming, constrict. So blood is coming, I know the volume is low, but the blood cannot get out. Blood start to accumulate, so more intraglomerular pressure. More intraglomerular pressure, okay? So this will preserve the GFR. The fluid will stay here, it will not get out. More fluid here, so more GFR. This is how we protect the kidney, okay? This is the normal physiological mechanism preserving the kidney function after the blood loss through the action of the angiotensin 2 on efferent part of the glomerulus. This will lead to increase of the intraglomerular pressure, the infiltration fraction, and then the GFR. Okay, let us go for the clinical applied part, which is related to the treatment that are related with angiotensin blockers. If we give a drug that block the ACE or angiotensin 2, the end result is no angiotensin 2, either by blocking the enzyme or the receptors. We know that all of us, I'm quite sure, all of us, the 101, the 100 candidates, we know that the best drug used for ACE inhibitors, the best drug used for patient with diabetes is ACE inhibitors. Diabetes with hypertension, what is the treatment? ACE inhibitor. Okay, why we give ACE inhibitor for diabetic patient, and why are the first line for diabetic patient and even for proteinuric chronic kidney disease? Let me just give you an overview about the effect of diabetes on the glomerulus. If we have diabetes, so we have hyperglycemia. More blood glucose, it will affect the basement membrane through a complicated mechanism. Hyperglycemia will affect the basement membrane. It will lead to damage of the basement membrane and the nodule, Wilson nodules, or as I remember, the nodules, the pathological nodules, and nephropathy, diabetic nephropathy, and then chronic kidney disease. Okay, so how diabetes affect the kidney? The most important part is through directly hyperglycemic blood directly affect the glomerulus, the basement membrane, sorry. Directly affect the basement membrane. The second thing that diabetes causes hyaline arteriolosclerosis. What I mean by hyaline, this is a blood vessels, this is the wall. In any blood vessels, usually hyperglycemia will affect the endothelium integrity, okay, and the plasma will get into the blood vessels. So the blood vessels will be filled with protein. The wall of the blood vessels will be filled with protein, so the wall of the blood vessels will be rigid. This is called in pathology arteriolosclerosis. It's not arterial, this is arteriolosclerosis. Diabetes also causing arteriolosclerosis in the efferent, make it rigid, constricted. This will lead to more, if you make the efferent more rigid, this will lead to more accumulation of the pressure within the glomerulus, and more pressure against the basement membrane, more exposure to the hyperglycemic blood, more kidney damage, and more progression of diabetic nephropathy. How to protect this? The first thing, by optimization of your blood glucose. This is the primary cause. The second thing is, which might happen initially or acutely, is to decrease the intraglomerular pressure. If you decrease the intraglomerular pressure here, if you decrease it, so this means that you will decrease the exposure of the basement membrane to the hyperglycemic blood, which will mean that the progression of the disease will be delayed. So if you give angiotensin II receptor blocker or AC inhibitor, you will mitigate the action, or you will prevent the action of the angiotensin II on the efferent. No angiotensin II in efferent. So the end result is vasodilation of the efferent. Vasodilation of the efferent will lead to most of the blood, they come and get out. So the pressure within the glomerulus will decrease. So this will lead to decrease of the intraglomerular pressure, decrease of the exposure of the basement membrane to the hyperglycemic blood, and then to delay the progression of diabetic nephropathy. This is why we give AC inhibitors in patients with diabetes. The second thing we have to mention, AC inhibitors and ARBs, they are contraindicated in patients with AKI. Patient with acute kidney injury, we are trying to preserve the GFR, not to decline it, okay? If you give AC inhibitor due to whatever cause, even in chronic diabetic patient and so on, and you measure the GFR before giving the drug, and you find that the GFR is 120, okay? You give AC inhibitor, you decrease the intraglomerular pressure, GFR might be 90 because the intraglomerular pressure decreased, no problem. This is what is reflected by we permit increasing of creatinine up to 30% from the baseline when we give AC inhibitor. If you give AC inhibitor, you have to do baseline RFT and you review the patient after 2 weeks. Increase of the creatinine, which means decrease of the GFR up to 30%, is permitted, okay, is permitted, no problem, because our goal is strategic goal to preserve the kidney. We don't have a problem with this just decline in the GFR. Patient with AKI, we don't know what is happening now in the kidney. We are trying to preserve the GFR. Don't give AC inhibitor, because AC inhibitor, they decrease the GFR. But if the patient is already diagnosed as a chronic kidney disease and has proteinuria or so on, the best treatment is AC inhibitor, because the AC inhibitor also decrease the intraglomerular pressure and the proteinuria and the complication related to the proteinuria and the progression of the kidney. So this is about the rule of ACE inhibitor, why we give in patient with diabetes, why it is contraindicated in AKI. Okay, so let us move to another important point. One of the very important questions is ACE inhibitor is contraindicated in bilateral renal artery stenosis. I think all of us know this. Huh? But why for they are contraindicated? This is the glomerulus, this is the afferent, and this is the efferent. Patient taking ACE inhibitor, already you vasodilate the efferent, already you decrease the pressure here, okay, because you have a strategic plan. We don't accept even decreasing the blood supply coming from here. If you decrease the blood supply coming from here, this will shut down the glomerulus. So you will decrease the blood supply, and the small amount of the blood coming, they will get out immediately through the efferent because of the vasodilation. So no blood here. No blood here, no filtration, so severe renal failure. So do you think that patient with, so what do you mean by decrease of the blood supply? If the patient has renal artery stenosis, so the blood supply is coming through the afferent will be decreased, okay? And at the same time, the efferent is dilated, so no blood will be within the glomerulus, and this will lead to very declining of GFR. This is why ACE inhibitor, they are contraindicated. Actually, we cannot diagnose it. I don't look for the patient, Mr. Muhammad. I believe you seem to have a bilateral. No. Usually, the clinical scenario like this: patient with hypertension, elderly, ischemic heart disease, diabetes, blah blah blah. You did your investigation. You start your management with ACE. 2 weeks, the patient come to the clinic. You find the creatinine raised 60%. Then you consider this could be bilateral renal artery stenosis. You stop the drug and you investigate for the underlying causes. One of the possible causes is bilateral, but other possible causes might be co-pathologies, maybe diarrhea, hypovolemia, nephrotoxic drugs, blah, 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 and so on. Okay, so this is about the physiology of the renin, angiotensin, and aldosterone system and the clinical application. Other things we might face later on in the topics, we will go through them and explain them. If you have any question, you can write on the chat till now. We will move to the next part. This is about the basic physiology related to the kidney. We have the nephron physiology, and also we have the renin, angiotensin, aldosterone system. Let us move to talk about the approach to RFT. Okay. The basic function of the kidney is the filtration, and we calculate the filtration through the GFR, okay, which is the glomerulus filtration rate, okay. Okay, if you are going to, if you need to ask from now, okay, we will give you 5 minutes maybe for questions. I will allow everyone to unmute. Okay, if you have a questions, you can ask, doctor.
Hello.
Hello, doctor.
Okay, as earlier it was said that according to physiology, that we have got 80% blood supplies toward the cortex region of the kidney.
Yes.
First, what is the region that we have got a lot of blood supply over there as compared to medulla? And the second one is papillary necrosis. We have got renal papillary necrosis. Do we have any specific artery which has been blocked over there, and it is leading to renal papillary artery necrosis? And the next thing that you said that we have got Bartter syndrome and Gitelman syndrome.
Yes.
In Bartter syndrome, can we have a clinical sign that we can understand without giving any examinations to the patient? Can we have a clinical sign to diagnose a Bartter syndrome or to differentiate it from Gitelman syndrome? And
okay.
this is, and the third question is that we have got patient with diabetes patient, as we said that we are going to start the first choice is EC inhibitor, angiotensin converting enzyme inhibitor. Let me ask you another question in that that we said the sodium glucose transporter we have got, or co-transporter, we have got kind of gliflozin, the drug which is being used for the diabetes. You know, do we have such that the main side effect of that drug in the patient that we are advising for the diabetes, since it is blocking in the proximal region, it is blocking sodium glucose co-transporter. What is the name of this transporter? In the next, does this drug canagliflozin, it has got effect over in GI system? Do we have any such kind of channels or transporter over there in GI system, in which is leading to decreased level of glucose?
Okay, well, very good. Okay, any more questions, Doctor?
We have got many questions, but if it would be better if we do, I know your lecture pattern is very good. You know, it is actually, we can say we appreciate that we have been in this seminar today. If we teach stepwise, as you said that earlier in your explanation, you said that in some books we have got flights of idea. It means the flights of idea, you mean there that we don't have any stepwise explanation. In step up, you just only presented an example. We have got lung QT syndrome. It is first explained, then we have got arrhythmia, then pericarditis, these things. So as I think the step up books or other books which are written, they are depending upon the notes. So those might be the topics which are being brought in the MRCP part 1. So that's what they have brought it, we can say not in sequence form. So I think our explanation, which is going on now in nephrology, if we have been given time stepwisely, now you explain the whole, it means nephron. The whole nephron, if we can say switch to another topic, before going to another topic, it would be better to ask questions to solve everything. You talked about renal failure, you went to renal failure, you pointed out some genetic mutation which is taking place in the sodium chlorine co-transporter. So, you know, Gentleman syndrome, as you talked about that, about Bartter syndrome, as you talked about that, if we just only present them as a scenario, as I think it would be better. Clinically, we don't know genetics, what happens in the in the sodium potassium to chlorine transporter, which is in distal convoluted tubule. If the gene which is coating this channel, if it is mutated, so it is leading to Bartter syndrome. So it is clear, but clinically, how do you diagnose? I mean,
yes,
in RCP, the question will not be brought like this, that if there is mutation, which gene is mutated, that gene is located in which region of chromosome, long or short arm, in which region. That wouldn't be, as I think, like this in MRCP, as I think myself. But it would be better to have a clinical scenario for presenting each question.
Yes.
As you recently you presented that we are not able to give EC inhibitors for the patient who have got bilateral, bilateral renal artery stenosis. So we are not advising. You said because it is decreasing GFR. No, it is decreasing GFR because it is decreasing. It is also it is potentiating renal hypoperfusion state, in which is leading to renal shutdown. But if a case is presented in this scenario, I think it would be better that the patient comes. Usually it happens in youngster. Maybe it might be unilateral, maybe bilateral. If it is unilateral, will not lead to renal shutdown. If it is bilateral, will lead to renal shutdown. In the patient clinically, how do we diagnose the patient? How patient comes with, which complaints? I think main focus, as I have got information, if it is over on scenario in presenting, it means the pathology, it would be, as I think, my idea. My question is clinical differentiation between Bartter syndrome and Gentleman syndrome, 1 point. And the next question, as I asked earlier about EC inhibitor, as well as about the mechanism that you talked about, ROS, you talk about EDH, that EDH, we have got aquaporin channels. Which channel is over there? We talk about RAS system that we have got, angiotensin has got only not functioning. It is also called vasopressin, which has got vasoconstrictor effect, and it's a secondary stimulator for the secretion of aldosterone. So if scenario is given, it would be better, as I think.
Okay, well, just let me start by your last concern or your last issue. This is just an overview. Even we don't move. This is as in the start of the lecture, if you remember, we said that we classify this nephrology into the basic, physiology, into the approach to RFT, into the renal failure. When we come to renal failure, we will go in details of the clinical scenarios of how to manage. This is just an overview of the basic concept, which is linked. When we go for this
in
is
overview, sir, in overview, we have got also a question. No, you explained that we have got angiotensin 2, which is located over on the efferent arteriole. We have got receptor for that. The name of that receptor, which is located over there, it is working to which pathway that you explained that in pharmacology question will be brought as well as it is CAM pathway or it is PIP3 pathway, which pathway it is working on. Do we have such receptor in the afferent arteriole or not? Why we have got more there and why we have got less there? So these are all questions in the basics.
I know this. I mean that this lecture is composed of, because the time, doctor, the idea of the lecture is, yes, as one of the candidates said, we cannot go even for all of the detail. The function of the lecture is to make the studying is more easier. The first part of the lecture is to take an overview and to organize our ideas. Then we will go for the renal failure and how it happens and the details. Then in the endocrine, we will go for the Gittelman departure. Now you have, for example, who is just listening to this part, he knows the basic concept. When we go for the clinical concept, it will become very clear. When we go for the clinical presentation, even in the course, we have questions, we solve past test on exam and so on. Then we will discuss it again and again. So the picture will become very clear. We cannot put them all in down. If you go through the details of all of them clinically now, so the lectures is lost, and this even I cannot put a topic for this lecture because the lecture become endocrine, nephrology, blah, 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 and so on. So it is just a trial of organize the idea initially. It is just an organization, okay? So the second question is about the gliflozin. Gliflozin, I mentioned that they are best used for patients with diabetes and heart failure. I link it to the basic. I'm not talking about diabetes now. When we go for diabetes, we'll talk about the guidelines, we'll go for the presentation, we'll go for the answers, we'll go for all of the stuffs you mentioned. But now we just mention a point that is relevant to the structure of the kidney. And if we go for the diabetes, you will remember what we mentioned here. And you said, yes, now I understand the concept. I don't need from doctor just to know that gliflozin, they are contraindicated, they are better for heart failure, and just to memorize it. In this lecture, this is a basic related to a clinical concept, so they understand, okay? When we go for the clinical, this is just an overview. Even we don't move to the clinical part. We don't start the clinical part yet. The other question is about Barter and Gittelman, as we mentioned, as a clinical scenario, we will present the clinical scenario, even we will present question in the endocrine. They are mentioned in endocrine, in the past medicine, and also many books that are mentioned in endocrine questions. The GFR, the other gliflozin, the side effect of the gliflozin, the blah, 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 all those details, they will be mentioned with the corresponding topics. This is just an overview to start first one topic, okay? I think from this trial, we will go to delay the questions even after the lecture,
just
because
just quick one, Dr. Fataraman. Just quick one. First of all, thank you so much, Dr. Fataraman, for this nice lecture, giving us the basic. Actually, I really appreciated it so much. Our understanding has never been to this point. So thank you for that. Going straight to the point, I have seen in the GFR before at the nephron that there was an afferent where the blood enters the kidney and then leaves at the efferent. I think to ask the question, the blood was, the intention was for the blood to enter and be filtered. But why does it slush off at the efferent? That's the only question I wanted to know. And I'm really very happy for this
Okay.
basic
Thank you.
concept, Dr. Shukran lek shadid.
Thank you, Doctor. As this will be the last question now, and we will delay the question up to the end of the lecture because the time of the doctors. We appreciate all of you and your questions. Thank you very much. So let us start by talking about the last point mentioned by Dr. Ramzi, I think, is about why the blood is leaving. You know that if this is the kidney, this is the glomerulus, this is the afferent, and this is the efferent, okay? The efferent, you know, the blood is not coming from the efferent to the outside, no. From the efferent is coming to the peritubular, okay? So the blood is go through if this is the tubules, the blood supply, they are peritubular, okay? So this is, I don't like to go for the details of physiology and so on, but to understand some of the materials in pharmacology, pharmacologists say that some of the material they got out through the filtration. Some of them, like uric acid, for example, like some drugs, thiazide, they get out through the active secretion. Active secretion from the peritubular blood vessels, okay? They will secrete the blood, the drug or the material or whatever, like uric acid, actively, active secretion. So they are peritubulars, okay? They are reabsorbing, they are secreting, and a lot of exchange that might happen in the kidney. The exchange in the kidney is not just at the level of the filtration. This is the next part we are going to talk about, which is the approach of the RFT. And let us start to talk about the approach of the RFT. Thank you, doctors. Okay. The approach of the RFT, the main function of the kidney is the GFR. In the kidney, we are not going to, if we have a patient in the ER and they say that this patient has acute kidney injury or AKI, we have to know what's the kidney function now. Physiologists say we have to measure GFR. How to measure GFR? We are going to measure the glomerular filtration rate. Physiologists say that let us take the patient to the physiology lab and infuse inulin in this patient and measure the clearance of the inulin. Physiologists use inulin for the GFR measurement. What is the idea of this? The idea of this is like this. If this is the kidney, and this is the filtration, and here is the urine. The exchange of material in the kidney occur at 3 levels. The first one is the filtration. Here, filtration is happening. For example, inulin is fully filtrated here. Inulin is coming through the tubules. One of the very important function or one of the very important characteristic of inulin is not reabsorbed. It's not secreted. I mean, it's not secreted, so it's not going through the efferent, coming back and secreted again. Once filtrated, once appear in the urine. So if we have 10 grams of inulin or 10 milligram, whatever, is getting out, I give you 10 grams of inulin. I found it in urine 10 grams. What is my understanding? All of this inulin is coming through the filtration because the inulin is not reabsorbed. If reabsorbed, so it will come here like 7, 4, 3, according to the amount absorbed. If secreted again, I might filtrate it 10, but I found here 12 because part of them, they are actively secreted. So the idea I will trying to give you that we have in physiology something called reabsorption and active secretion. Active secretion and reabsorption will affect the amount. In renal function, we don't need secretion or reabsorption. We are talking about glomerular filtration. So what is the characteristic of the materials or of the items we can use for the calculation of the GFR? Neither absorbed or secreted. Okay, we cannot give the patient or get the patient to the in physiology lab, but we have in our body a protein called serum creatinine. Serum creatinine is released from the muscles, which is very important because the difference in the muscle mass will affect the serum creatinine. People with large muscle mass, creatinine will become greater. People with small muscle mass, like cachexic patient or patient with liver cirrhosis, a lot of studies are talking about the sensitivity of the creatinine in renal failure in patient with liver failure and so on, because most of them, they have very low creatinine. So creatinine is released from the muscles. Okay, once released from the muscle, it comes to the kidney and filtrated. It is not absorbed, slightly secreted. We can say is not secreted. Once coming to the kidney, it will get out. So we use creatinine for the assessment of the function. Creatinine is affected by many factors. One of them is the muscle mass, the ethnicity, the age. The creatinine is normally excreted 1 gram per day. And the normal serum is 0.8 to 1.2 or 1.3 in some references. If your creatinine exceeding 1.2, so this means that the filtration is affected. You cannot say there is active secretion or reabsorption because it's not reabsorbed, it's not secreted. So this is why we use the creatinine, okay? Unfortunately, creatinine started to increase after losing 50% of the kidney function. This is a very important point, okay? The question is about in which case we have false positive raised creatinine. I think we have many diseases that might, or not many diseases, like in patient, for example, as I remember, what come to my mind now, in general, patient with large muscle mass, you have to make sure that the creatinine is not affected, because sometimes they have creatinine level more than normal patients. Okay, I will revise it and I will come you at I will tell you inshallah within the end of the lecture. Okay, the second thing we are going to talk about is the urea. Okay, urea and the concept of the blood urea creatinine ratio is very important, because if you open step up to MRCP, the first question you will be faced with is how to interpret urea creatinine ratio. How to interpret urea creatinine ratio. Urea is coming from what? Urea is coming from the metabolism of amino acids. Okay, amino acids, they are converted in the liver. Before going to the liver, they will be converted to ammonia. Ammonia is converted in the liver to the urea. Urea in the kidney is getting out in the urine. Okay. So urea is excreted through the kidney. Urea has a very important characteristic. It is an osmotic. I mean, if we have a patient with hypovolemia or blood loss, patient with blood loss or hypovolemia, usually the human body, to compensate, will start to reabsorb sodium, which is followed by water in the proximal convoluted tubules. One of the other solute that is also reabsorbed in response to hypovolemia is urea. So usually in patient with hypovolemia, hypotension, in the first time or the first period, usually you will have a very high urea. The high urea is not related to the loss of filtration. No, it's filtered, but is reabsorbed. Why for it is reabsorbed? Okay, it is reabsorbed because of the compensation to retain the water. Also, the water is coming back with urea. This is why for in patient with renal failure, usually they have a very high urea compared to creatinine. This is called high urea creatinine ratio. If you don't treat the patient, if you don't give the patient the fluid, okay, or the treatment he needs, After that, the function of the tubules will be affected, and the tubule will be necrotic because no blood. Okay, no perfusion, so no blood, so the fluid will be necrotic, and this is called acute tubular necrosis. It's very important to know that one of the most important cause of acute tubular necrosis is a pre-renal renal failure. Okay, pre-renal renal failure, patient with hypotension, with sepsis, with shock due to any cause. Usually they have a low blood supply. Initially, you will have a urea is very high compared to the creatinine. I think as a doctor, high urea creatinine ratio is very good for us, because this means the patient might respond to your treatment. He might respond, and many respond, because the tubules, they are still functioning. How I know that the tubules are still functioning? Because the urea is high. So this means that the tubules still has the ability to reabsorb. Okay, so if the patient has low urea, you won't be happy, because low urea, this means that our low urea creatinine ratio, I mean, this means that the tubules lose the ability to preserve the urea and reabsorb the urea, and this is called acute tubular necrosis. This is what we are going to talk about, inshallah, in the upcoming part of this lecture, which will be acute renal failure, and what is the significance of pre-renal renal, or what is the significance of the urea creatinine ratio. We are going to the talking about acute tubular necrosis. We'll go about it. Okay. طيب, Dr. Ismat is asking about amino acid for urea. You won't be asked about the source of about the type of amino acid in urea, but if you need a lecture, I have I'm also an instructor for USMLE step 1 and step 2 CK course. I have about 70 lectures of biochemistry in details, talking about all of the pathways, urea, creatinine, and so on. If you need it, I will send just samples, but they are in Arabic. Inshallah, in the future, we are planning to do lectures, inshallah, in English also. Okay, let us move on and talk about the acute renal failure. Then we will go for the chronic renal failure. Okay. Acute renal failure is a very important and a very common disease. Acute renal failure. We can say acute kidney injury. All of them, they are accepted. By the end of the lecture, we'll go through the notes and we will just review what we talk about. And I think, inshallah, all the topics will be clear for you. Okay. The notes is the same past medicine notes and step up note, but I just recollect them and just reorganize them to read it very simply, and you can proceed with them after the lecture. It will be very easy, and then you will go for answering past medicine, past test, or on exam, inshallah. Okay. Acute renal failure or acute kidney injury is a deterioration of the kidney functions within days. This is a general term. This is not the definition or the scientific definition. So what is that? But in general, the AKI is the deterioration of the renal function within days. Okay. So what do we mean, or scientifically, what do we mean by deterioration? We have three major criteria. Either creatinine, increasing of creatinine more than 0.3 from the baseline. All of this will be found on the notes, okay? So increase of the creatinine 0.3 from the baseline. Okay, the second question, all AKI or acute renal failure, all of them are the same? No, they are not the same. They are not the same, okay? In MRCP, they are not going to ask you about staging of the acute kidney injury or so on. But the issue is you have to know just that the staging system for AKI, we know the staging system for chronic kidney disease, but the staging system for AKI is 1, 2, 3. 1 is increasing 1.5 to 1.9 from the baseline. 2 is increasing from 2.0 to 2.9 from the baseline. 3 is increasing more than 3 from the baseline. If you have more increasing of the creatinine, so more declining of the GFR, so more problems. Before going to talk about what are the symptoms, what are the blah, 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 the most important is to talk about the causes of acute renal failure. In MRCP, they are not going to ask you about the criteria for the diagnosis of renal failure, okay? Because sometimes renal failures could be diagnosed with the urine output. And this is what we see usually in the ICU, HDU. You observe that the patient the urine output is decreasing. So this is an alarm for acute kidney injury. So decrease of the urine output less than 0.5 ml per kg per hour, more than 6 consecutive hours. This is AKI. You don't have to memorize, okay? Causes of AKI, we have pre-renal, renal, and post-renal. Okay, what do we mean by pre-renal, renal, post-renal? If we are going to the kidney, it's very important to know the causes. If you have a patient with AKI, the first thing you have to ask yourself, what is the cause? Because what is the cause, this means what is the treatment? If you know the cause, you know the treatment. You know the prognosis, you know the chances of recovery, and so on. So pre-renal is a simple idea of decrease of the blood supply through the afferent, so low filtration, low GFR, appear as high creatinine. This is the causes of the pre-renal failure. So what are the causes in general of the pre-renal renal failure? Like hypovolemia, like burns, like shock due to whatever cause. Shock by definition is a tissue hypoperfusion, okay? So a lot of causes, all of them, they will lead to decrease of the blood delivery to the kidney, either due to the decrease of the volume, as we mentioned, in patient with hemorrhage or patient with low cardiac output. We know that patient with heart failure, for example, or decompensated heart failure, usually they have a very low cardiac output, okay? Very low cardiac output. This will affect the kidney finally, yeah? And this is called cardiorenal syndrome, in which we have 5 types, but the part we are talking about here is decreased cardiac output, decreasing delivery of the blood, and so decrease of the GFR, and so renal failure. Sometimes drugs in hospitals, according to the practice, I think sepsis is a very important cause. Many of the times presented patient to us, for example, here in Sudan, a lot of patients presented with maybe UTI, pneumonia. They don't treat it well. They presented to you confused in the ER. What is the cause of confusion? You find this is septic encephalopathy. Confusion because of sepsis. Sepsis causes decrease of the blood delivery to the organ, and the first organ to be affected is the brain. The patient will have confusion, okay? You check the kidney function, you find it impaired kidney function. If you give him generous IV fluids, you give him antibiotics as early as possible, the patient will be reversed most of the time. So sepsis is one of the causes of the pre-renal and one of the very important causes. All of the causes, you have to treat them with replacement, and we will go to talk about this in the management. Before moving to the renal causes, very important point to mention here, which is what? The point is that many patients already at risk. If I have patient maybe with diabetes, hypertension, patient taking AC inhibitors, for example, or patient taking non-steroidal anti-inflammatory drugs. Non-steroidal, they prevent the release of the prostaglandin or the formation of the prostaglandins. If you don't have a prostaglandins in the kidney, they are vasodilators. Okay, so they are vasodilator on the afferent. No prostaglandin, no vasodilation, so the amount of the blood will decrease. So this is a contributing factor for the renal failure, and this is usually why we advise to limit the intake of the NSAIDs in elderly patients because of the renal and gastric issues, as we know. Okay, so many patients, they will be at risk of the renal failure. We have to know them very well before proceeding to anything that might affect the function of the kidney. Let us go to talk about the renal causes. The pre-renal, I don't think that there is difficulties with dealing with. Okay, I decided to go about the management and symptoms and signs. Pre-renal, then we go for renal, then we go for post-renal. Let us talk about symptoms and signs. Usually the symptoms and signs of renal failure, they are non-specific. They are related to the poor function of the kidney to release fluid, and also related to the metabolites that are accumulating in the human body. Usually they have nausea, they have vomiting, maybe abdominal pain, and so on. The serious issues, they are related to accumulation of uremia. Accumulation of uremia, we might have uremic encephalopathy. We might have uremic gastropathy, okay? Uremic pericarditis, it causes fibrinous pericarditis. Those, all of them, they are related to accumulation of uremia. Also one of the very important things of the symptoms of the acute renal failure is the decreased urine output. And this is usually observed in admitted patient. The other, sometimes the patient himself told you that he feel that the urine is not as usual in amount. The second thing is also the symptoms of fluid overload, because the kidney is responsible for the filtration of the fluid. Fluid overload mainly in the form of the pulmonary edema, or this is the critical thing. Other things is lower limb edema, periorbital edema, and so on. Okay, so those are the major symptoms of the renal failure. In general, acute renal failure is diagnosed through the investigations. Okay, the symptoms, like symptoms of uremia and fluid overload usually appear on ill patients. Okay, then those are the symptoms. Then you go for the investigation. The most important part of the investigation of the AKI is to look for the urea creatinine ratio, or blood urea nitrogen creatinine ratio. It's very important to note that there is a difference between urea and BUN. BUN is the nitrogenous component of the urea. Okay, BUN is the nitrogenous component of the urea. So if the urea is 100, the BUN will be about 40. Usually the lab will give you BUN, will give you the urea. BUN over creatinine more than 20, or urea creatinine more than 100. This means that we have pre-renal renal failure. Creatinine may be elevated too. Urea will be 200, BUN will be maybe 100. This means that very high urea. This means that the tubule, they are still functioning. Okay. So usually in pre-renal renal failure, urea creatinine ratio is high. BUN creatinine is over than 20. We have to check the urine sodium and urine osmolarity. The urine sodium usually is low in pre-renal renal failure. Why 4 is low? Because still the tubules has the ability to concentrate and has the ability to reabsorb the sodium. The concentration of the urine in the pre-renal failure, usually the concentration is high. Okay, because the tubule has the ability to reabsorb the water. So the solute, they are concentrated in the urine. This is what we find in the pre-renal. About ATN, we are going to talk it later. Okay, how to manage pre-renal failure? It is mainly supportive. If we are going to talk, it is not a nephrology webinar or a nephrology it's not about, this is about MRCP guided lecture. Okay, They are not going to ask you in MRCP the details of management of pre-renal, blah, 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 what we did in the hospital. Usually in the hospital, if you have a patient with the pre-renal renal failure, if you know a known cause, you just treat the cause, you replace the fluid, you follow the patient. Many times, patient presented to us, maybe in the OPD or the outpatient clinic, with impaired RFT. We don't know this is acute or chronic. Okay, we don't know this is how to differentiate acute or chronic. One of the important things, but unfortunately it appears later, is the abdominal ultrasound. If you find shrunken kidney, this is chronic. We have to note that there is differential diagnosis of CKD with normal sizes like polycystic, like diabetes, amyloid, and so on. The other thing, this is a late sign. Other investigation that might help is hemoglobin, uric acid, parathyroid, calcium, phosphate, and so on. Just I remember now that in MRCP, maybe 2017, one of the questions was about the renal function is, what is the first biomarker that increased after renal failure? As I told you, creatinine just increased after losing 50% of the function of the kidney. The first biomarker increase is cystatin C. Cystatin C come a lot of times. Thank you, doctor. A lot of times is seen in many exams. Cystatin C is the first biomarker to be increased, and sometimes is used in some formula. In some formulas that calculate the GFR. Okay, let us go for the management of pre-renal. We can just mention is supportive, plus if there are signs of or indication of urgent dialysis, we have to go for dialysis. What are the signs of urgent dialysis, or what are the requirements for urgent dialysis, or the features that mandates urgent dialysis? We have clinical and biochemical. I think all of them we know. Resistant hyperkalemia, because hyperkalemia is a cause of cardiac arrest. We also have severe acidosis. We also have, and this is about the chemical manifestations. Clinical, we have uremic acute pulmonary edema is resistant to treatment. We have uremic encephalopathy. So those, and also in addition, we have, I think, 2 additional requirements for urgent dialysis. I will tell you about the idea of the dialysis when we are going to talk about the chronic kidney disease. Okay, so we have to support the patient usually to maintain a good volume status. The second thing is the treatment of the by dialysis for the serious problem that mandate urgent dialysis. One of the very common questions to be seen related to the acute renal failure is the hyperkalemia. And the first thing is, what are the ECG features of hyperkalemia? The first thing is 10T wave. Okay, after 10T wave, you might have loss of P wave, paralysis. You might have white QRS complex. All of them, they are ECG features you might see in patient, and you might also see asystole. This is cardiac arrest. You treat hyperkalemia if the serum potassium is more than 6.5. What is the treatment? Is very important to know. Calcium chloride or calcium gluconate. The major function of the calcium, no doses in MRCP. Calcium chloride, the main function is to stabilize the heart, is not to excrete the potassium. The other function of the or the other treatment is to shift the potassium. Okay, shift the potassium, I mean, if this is the blood vessel, this is the cells, we have to move the potassium from the into the intracellular compartment. Okay, so in the serum it will be decreased. So how to shift the potassium? We have to give insulin. Insulin is leading to shifting, but unfortunately it causes hypoglycemia, so we have to add dextrose. Other than insulin, what we have to give? We have to give also salbutamol. Salbutamol also leads to shifting of potassium inside, but we need a higher doses like 10 to 20 in the treatment. then we might give polystyrene and to release the potassium out of the soil or out of the human body. Usually we start our treatment for hyperkalemia. If the patient is responding, that is good. If not responding, we go for dialysis because hyperkalemia might be the cause of the cardiac arrest in a patient with acute kidney injury. Okay. Let us go and talk about the renal and post-renal. Okay, insulin shifting of how does insulin shifting potassium? Insulin is anabolic hormone. Anabolic I mean is anabolic بالعربي كده يعني by Arabic بنائي تمام. And if we need to build anything, we have to give them. Okay, if I need to build a home, I will put sand, I will put rocks, blah blah blah, and so on. In blocks, if you need to build a cell, you have to give him what he needs. Cells usually need glucose, they need nutrients, they need electrolytes, and so on. So this is why insulin insulin as a mediator of, or is very important to transport glucose into the cell, glucose transporter. It also mediates the uptake of many things into the cells. One of them is potassium. Okay. This is, I don't think this is asked in MRCP scenarios. The other part we are going to talk about is the renal causes. Renal causes, they are very important and sometimes they are conflicting. Renal causes, before going to talk about the renal causes, we have to know what is the structure of the kidney. If you look for the kidney has a blood vessels. So we have vascular problems that might happen. We have glomerular. We have tubules. The process of the reabsorption between the tubules and the blood vessels is occurred through the interstitium. So the renal has vascular, glomerular, tubular, and interstitial parts. All of them, they are contributing to the function of the kidney. If any one of them is affected, okay, so this means that the patient might have a renal failure. Let us start by the most important, which is glomerular. So glomerulonephritis is one of the causes of the acute renal failure. Glomerulonephritis types, causes, treatment is discussed in another lecture. Okay, so one of the causes of the acute renal failure is glomerulonephritis because it affects the glomerulus itself and the process of the filtration. Other causes is the vascular. Blood vessels is very important to maintain the filtration, the absorption, the secretion, and other function of the kidney. So any disease affect the blood vessels will lead to the renal failure. So this is vasculitis. Okay, so we have vasculitis due to vascular, glomerulonephritis due to glomerular. We have tubular. Tubular, we have acute tubular necrosis. This is the most important. What is acute tubular necrosis? This is a very important topic. This is the renal tubules. The function of the renal tubule is to absorb and secrete. Okay, absorption and secretion. Sometimes, if the patient has pre-renal renal failure, so no blood supply is coming to the kidney, so the tubules will undergo necrosis. No blood supply is coming. It's not coming through here, it's not coming through the efferent, it's not coming through the peritubular. So where is the blood supply to the tubule? No blood supply to the tubule, so the tubules will become necrotic. This is called acute tubular necrosis. So the first and the most important cause of ATN is pre-renal renal failure. Sometimes we have another causes. What are the other causes of acute tubular necrosis? some materials or substances, they are directly toxic to the tubules. Directly toxic to the tubules, so they are causing injury and necrosis of the tubules. Like what? On top of them is myoglobin. So what is the scenario? We have a syndrome or a disease which is called rhabdomyolysis. In rhabdomyolysis, what do we have? In rhabdomyolysis, rhabdo means skeletal muscles. Skeletal muscles. Myolysis is a breakdown of the skeletal muscles. So sometimes patients, they have breakdown of the skeletal muscles. One of the very important protein that is functioning in the skeletal muscle, like hemoglobin, it is myoglobin. Myoglobin function in the skeletal muscle is to give the skeletal muscle oxygen very quickly, okay? So myoglobin is normally found in the skeletal muscle. It is red in color. Once the skeletal muscle, they are destructed, it will be released. It is red in color. It is released and come in the kidney. Come in the kidney, okay? And then it is directly toxic to the tubules. It is causing acute tubular necrosis and renal failure. What is the clinical scenario? Here is the first important clinical scenario we are going to talk about. What are the causes of the rhabdomyolysis? One of the very important causes of rhabdomyolysis is seizures. Seizures is electrical activity or abnormal electrical activity of the brain. If it happens on the motor area, so this will lead to motor stimulation of the muscles. This will lead to unopposed contraction of the muscles, sustained contraction. There might be depletion of oxygen, no ATP, necrosis. Necrosis, so after this status epilepticus, the patient presented to you in the ER with a red urine. Renal function is impaired. What is the problem? Seizure, uncontrolled fits, prolonged contraction, depletion of oxygen, necrosis of skeletal muscles, myoglobin release. It appears in the urine as a red urine. It causes acute tubular necrosis. You find that the patient has red urine. You do microscopy, no RBCs. So this is not hematuria. It's very important thing to know in the exam. This is not hematuria. This is myoglobinuria. It will give you a red picture, but no RBCs. The first cause is seizure. The second might be an injury or trauma. Sometimes extensive trauma is to the skeletal muscles will lead to the same issue. Sometimes prolonged bed rest is very important to mention this. It doesn't like to appear in the MRCP. I didn't find it before, but it's one of the known causes for clinicians. Prolonged bed rest and sometimes compression on some muscles. It might lead to and disuse atrophy of the muscle. This might lead to rhabdomyolysis. Sometimes electrical shock sometimes give you also rhabdomyolysis. One of the very common scenario is a patient in the marathon, running, exhaustion of skeletal muscles, and then the patient presented to you with red urine. This patient has rhabdomyolysis. Rhabdomyolysis might cause acute tubular necrosis. Patient presented with red urine. How to treat? The treatment is supportive. Sometimes drugs also is very important to know that the drugs might cause acute tubular necrosis. So usually the investigation, patient might have impaired RFT. Let us go for the urea creatinine ratio. Here, tubule, they are non-functioning, so it will be low. What about the sodium in the urine? It is high because the tubules cannot reabsorb sodium. What about the osmolarity of the urine? Is low. The tubules cannot reabsorb water. It's very important to know. To know this is acute tubular necrosis. This means that the tubules are no longer functioning. The treatment is supportive. One of the questions I met in past test is about patient presented with ATN. What is the chance that the patient might need regular dialysis? This means that the patient will become chronic kidney disease, and in chronic kidney disease, it will be stage 4 or 5, whom need regular dialysis. So let us understand what is the prognosis of ATN. I told you before, you won't be happy for ATN because ATN, the prognosis is 50-50. 50% retaining of the function, 50% is going to chronic kidney disease. If they go for the chronic kidney disease, as we will mention after, is 5 stage: 1, 2, 3, 4, 5. 5 definitely they need renal replacement therapy. 4 also sometimes need renal replacement therapy. What we mean by renal replacement therapy, either dialysis, or other than dialysis, we mean renal transplant. About just 5% of the patient of ATN, 50% they will go for chronic kidney disease, okay? But most of them, they will be in stage 1, 2, 3. Just 5% they might need regular dialysis of the all patient. This was a question. It's unlikely to ask about percentage of prognosis in the exam. It might happen, but it's unlikely. Okay, but it's very important for you as a clinician to know the prognosis of the case you are dealing with. ATN is worse than pre-renal. Patient with pre-renal, try to treat it before becoming ATN, okay, or acute urinary. On the other hand, the treatment is supportive. What do you mean by supportive in nephrology? IV fluid balance, avoid nephrotoxic drugs, and avoid any thing that might aggravate the conditions and so on, and let the kidney to regenerate. Okay, this is ATN, and the scenarios, the most important is rhabdomyolysis, marathon, status epilepticus, electrical shock, red urine, no RBCs in the urine. This is rhabdomyolysis. One of the causes of rhabdomyolysis is myocardial syndrome. So sometimes it's coming. What is myocardial syndrome? Myocardial syndrome is a glycogen storage disease. Glycogen is the storage form of carbohydrate in our body, either in the liver or the muscles. You know that muscle is active. They need glucose as quickly as possible, so they have their glycogen. We have muscle glycogen. If you are going to run, the muscle glycogen will be broken immediately. They will give you glucose to utilize it. Myocardial disease, they have a problem with the enzyme called glycogen phosphorylase or myophosphorylase, which is responsible for the breakdown of the glycogen in the muscles. If you don't have this enzyme, so the glycogen wouldn't be broken. So no glucose, no ATP, necrosis, rhabdomyolysis, myoglobin, ATN. Okay, this is sometimes is coming in the exam. Myocardial disease. The scenario of the myocardial disease usually in pediatric, 5 years, 6 years, who start to run with his peers in the school, started to develop calf muscles following exercise. Okay, this is the most likely presentation of the myocardial disease. So this is about the tubular causes. One of the causes of the tubular problem is through drugs. Some of the drugs, they are nephrotoxic to the tubules. They are like aminoglycosides, for example. Some of the also contrast nephropathy. Contrast nephropathy, I think, is very interesting to know what is the mechanism of contrast-induced nephropathy. Contrast is causing pre-renal renal failure, it's not causing tubular. Okay, just let me explain for you. This is it is found that the contrast causes aggressive vasoconstriction on the afferent, so decreasing of the blood supply. You will prevent this by maintaining a lot of fluid here. So the treatment of or the prevention of the contrast-induced nephropathy by giving fluid before and after. More fluid, so more volume in the vessels. Even there is vasoconstriction, the amount of the fluid, I think, would be enough. So the mechanism of action of contrast nephropathy is aggressive vasoconstriction in the afferent. They won't ask you in MRCP, but I think it's better to know. They ask you in MRCP how to prevent by give fluid before and after. Okay, this is contrast-induced nephropathy. As much as you can, don't give contrast for AKI. As much as you can, try another modalities of image other than contrast is better than using contrast. Let us go for the other causes. We talk about the tubular and glomerular and vascular. We have interstitium. Interstitium 100% will present on the exam. What is the problem? This is the tubules. Sorry. This is the tubules and this is the interstitium. Interstitium is very important as a base for reabsorption and active secretion and so on. If you have inflammation of this interstitium, so the function of the reabsorption would be affected. Okay, and the function of the kidney in general would be affected. This is called interstitial nephritis. And interstitial nephritis is classified as acute or chronic. If we are going to talk about acute interstitial nephritis, okay, acute interstitial nephritis is related to type 1 hypersensitivity reaction. It is usually a hypersensitivity reaction most of the time to drug. So the scenario is a patient receiving cephalosporins, allopurinol, non-steroidal anti-inflammatory drugs, sulfa drugs. Okay, he took the drug. The human body formed type 1 hypersensitivity reaction in which eosinophil is involved. The drug is coming to the kidney. Once coming to the kidney, the response happens. Type 1 hypersensitivity. Inflammatory cells are coming. They disrupt the architecture of the kidney and the basement membrane of the vessels. So they will leak out. So you might find eosinophil in the urine. Eosinophiluria is pathognomonic for interstitial nephritis. What are the other clinical manifestations? Skin rash, fever. Skin rash and fever indicate inflammatory reaction. Eosinophiluria, impairment of the renal function. After taking a drug, this is acute interstitial nephritis. Simply how to treat, just stop the drug. Sometimes it might develop into chronic interstitial nephritis. Chronic interstitial nephritis usually present as a chronic kidney disease, and you diagnose it after taking biopsy. One of the very important features of a chronic interstitial nephritis as a cause of the chronic kidney disease, they present very early with anemia. Why for? In general, patients with chronic kidney disease, they have anemia due to low level of erythropoietin. This is the most important mechanism. Erythropoietin is secreted from the peritubular interstitium. So erythropoietin is secreted from the interstitium. Patient with end-stage renal disease after the fibrosing have occurred all over the kidney. All over the kidney, the fibrosis happened. And then also the interstitium is affected and the erythropoietin release is depressed. In chronic interstitial nephritis, the interstitium is the first part is affected. The erythropoietin will be affected very early. So with a level of creatinine about 2, 2.5, 3, you will find that the patient has hemoglobin 8. This is one of the suggestive findings of chronic interstitial nephritis as a cause of end-stage renal disease or chronic kidney disease. Okay. Usually chronic interstitial nephritis, we might use steroid, but if it is chronic kidney disease, okay, it is chronic kidney disease. Okay, we treat it as chronic kidney disease. Acute interstitial nephritis, the most important is to stop the offending drug, which is the cause, and most of the cases, they respond just by stopping the drug. Don't forget eosinophiluria in addition to skin rash and fever after taking a drug, okay? So this is the interstitial causes. So all of them, they are the renal causes. Let us go and talk about the post-renal. So what do we mean by post-renal? Usually post-renal, this means that there is an obstruction. So if there is an obstruction, what is the problem? If there is obstruction, we mean that, or we told you that the most important function of the kidney is the filtration. If we have an obstruction, so this means that increase of the pressure in the ureter, increase of the pressure in the collecting ducts, in the proximal convoluted tubule, increase of the pressure in the Bowman space. Usually the filtration is a pressure gradient, fluid moving from high pressure to low pressure. If you have a high pressure, this is a backflow pressure. This will lead to, if the pressure is high here, so the fluid couldn't move on this direction, so the filtration will decrease. Okay, this is the idea of the post-renal. What are the causes? Either intraluminal, like renal stone, or extraluminal, like compression by cervical cancer, or so on. One of the very important to note that one of the drugs is causing crystalline nephropathy. It's very common to be seen on the exam. What is the name of the drug? As I remember, is acyclovir, which is an antiviral, is causing crystalline nephropathy, form small crystal within the tubules, obstructing the tubules. This is why it is advised to give IV fluid with acyclovir to prevent the formation of the crystal, which might cause an acute renal failure. It is an obstruction, but at the level of the tubules. Crystalline nephropathy is a very important mechanism of renal affection in patient taking acyclovir. I think it's common question, also appears on a lot of medicines exam, like MRCP exam. Post-renal causes, usually the investigation as the same. Ultrasound, you will find that hydronephrosis might be unilateral or bilateral according to the site. And also usually the treatment is to relieve the obstruction after consultation of urologists. This is about the renal failure. Okay, we talk about 2 hours till now, I think, but we are going to proceed, inshallah, maybe half an hour with chronic kidney disease. Okay, let me take 5 minutes break. Any one of you drinking water or so on? So 5 minutes break. So coming back to continue the lecture, by the end of the lecture, we'll open the chance for the questions. Okay, so now we are going to talk about the chronic kidney disease. This is the same idea. The chronic kidney disease is a deterioration of the kidney function for more than 3 months. Okay, more than 3 months, deterioration of the kidney function. So how it is assessed? Usually by the declining of the GFR, or clinically by the high creatinine. You cannot just rely on the high creatinine, you have to calculate the GFR, because after the calculation of the GFR, you have to stage the chronic kidney disease into 5 stages. Stage 1, 2, 3, 4, 5. Okay. This staging is depending on the GFR. How to calculate the GFR? We have a formula in which we put creatinine in addition to the muscle mass, in addition to the age and ethnicity, all of them together. The formula is usually used through the mobile phones. There is a formula actually, previously we memorized it, but no need. Okay, you can just open your mobile and use the formula to calculate the GFR. This is one of the calculation systems through the GFR. One of the calculation system is by using the albuminuria into 3 stages, 1, 2, 3. Frank proteinuria is the stage 3. But the most widely used system to classify chronic kidney disease is through the GFR. Stage 1, usually they have a GFR more than 90, but there is evidence of chronic kidney disease Stage 2 more than 60, but usually we need evidence of chronic kidney disease. Stage 3 into 3A and 3B. This is from the 45 to 60, and this is from 30 to 45. 3A, 3B. No need for evidence of chronic or clinically evidence of chronic kidney disease. Stage 4 from 15 to 30, and stage 5 less than 15. Any patient you diagnose them with chronic kidney disease, the second question you have to ask about yourself is what is the stage, because the treatment usually depending on the stage of the chronic kidney disease. What are the symptoms? What are the causes of the chronic kidney disease? The most common cause is diabetes. In some countries, the most common cause is hypertension. So diabetes and hypertension, they are the most common cause. Their prevalence is very high. Diabetes affects the kidney through the affection of the basement membrane, the vasculature of the kidney. Hypertension usually through affection the vasculature of the kidney. The third cause is glomerulonephritis, then polycystic kidney disease, then other causes, okay? Like maybe obstructions and so on, recurrent pyelonephritis, stones, blah, blah, blah. Those are the most common. Usually, when they ask you what are the causes, you have to mention the most common, even in the clinical exams. So those are the most common causes of the chronic kidney diseases. What are the symptoms of the chronic kidney disease? What do you think the symptoms? Usually the symptoms, they are non-specific. As we mentioned in AKI, the symptoms usually they are non-specific symptoms: nausea, vomiting, fatigue, abdominal pain, hypertension. The patient might present with the symptoms of the cause, hypertension, diabetes. Incidentally, you find them with chronic kidney disease. The symptoms might present with the symptoms of complications like symptoms of uremia, of fluid overload, of hypertension. Hypertension itself is a complication of chronic kidney disease. What about the prognosis of the chronic kidney disease in general? Usually the most common cause of death in patients with chronic kidney disease is very common to be seen on the exam. The most common cause of death is cardiovascular cause. Chronic kidney disease accelerates the atherosclerosis and hence accelerate the ischemic heart disease and other problems related to cardiovascular problems. This is the most important cause of death. Investigation for the chronic kidney disease, usually we request the general investigations like RFT, CBC, LFT, and so on. So depending on the scenario of the patient to know what is the cause. In general, we need to do abdominal ultrasound, serum parathyroid, calcium, phosphate, uric acid, all of them to manage the complications that are related. If we suspect obstruction, we have to do image. If we suspect diabetes, we have to investigate for diabetes. If we suspect glomerulonephritis, we have to do renal biopsy. We will talk about this when we are going to talk about glomerulonephritis, okay? The most important part of the chronic kidney disease is how to manage chronic kidney disease. The most important point is when to refer, slow the progression. Let me write when to refer. We will find the referring criteria in the note while we are going to revise by the end of the lecture. The second is slow the progression. The third is treat the complication. The fourth is renal replacement therapy. Okay. When to refer, we have criteria for referral like stage 4 and 5 patient with persistent proteinuria and so on. Other criteria will be revised later on. The second is to slow the progression of the disease. To slow the progression of the disease, or you have to know what is the cause. If the cause is the glomerulonephritis, so you have to treat the glomerulonephritis by immunosuppressant. If the cause is diabetes, you have to optimize the diabetes and you have to give ACE inhibitors or ARBs. If the cause is hypertension, you have to maintain the blood pressure and to treat hypertension in the patient. We're going to talk about the treatment of hypertension and diabetes in chronic kidney disease. Okay. What is the treatment of diabetes or chronic kidney disease, or how to treat diabetes in the chronic kidney disease? Usually, many patients with diabetes or with chronic kidney disease and diabetes, they need insulin. Okay, many of them, but it's not a rule. Regarding sulfonylurea, usually sulfonylurea is risky in patients with chronic kidney disease because of the risk of hypoglycemia, but some drugs could be used like gliclazide. Okay, gliptins also could be used. I think this is not the level of MRCP part 1. Okay, gliptins also could be used. This is about the drug that could be used. Also, another drugs, many drugs could be used of anti-diabetic agent, but with cautions and with doses, with small doses like than other patients. Okay, or we use insulin. Regarding hypertension, the first line is ACE inhibitors or ARBs to decrease the proteinuria. Many times in the hospital, patient presented with edema and proteinuria and impaired RFT. We don't know, is it glomerulonephritis, acute glomerulonephritis, or chronic kidney disease complicated by proteinuria. Proteinuria is one of the features of the end stage chronic kidney disease because the basement membrane loses the function and the protein is spilled out into the urine. So proteinuria is commonly to be seen in patients with chronic kidney disease, especially in the stage renal diseases. Okay, so the treatment is usually with ACE inhibitor or hypertension. So those are the progressions. Okay, we have to give also statin. This is about the complications. Regarding the complication, we have many complications. The first is anemia. What is the cause of anemia in chronic kidney disease? Erythropoietin deficiency. Usually patients with chronic kidney disease, okay? Patients with chronic kidney disease, they have low level of erythropoietin, which is a stimulating agent for the bone marrow to produce RBCs. So this is treated with replacement by giving erythropoietin, okay? When to give erythropoietin? If hemoglobin is less than 10. So you have to rush immediately for erythropoietin? No. Before giving erythropoietin, you have to check ion status. It's common to ask you in the exam. We give patient erythropoietin, but he didn't respond. Why for? Because the patient has ion deficiency. Ion deficiency has many mechanisms in chronic kidney disease. Usually they have nausea, vomiting, decreased absorption, and so on. So you have to check ion status. If good ion status, give erythropoietin. If not, correct ion initiating. After correction of ion, either oral or IV, then if the patient needs erythropoietin, you give erythropoietin. What are the side effects of erythropoietin commonly to be seen? Accelerated hypertension and hypertensive crisis. Other important side effect is headache, seizure. Also, sometimes the human body develop, or the human cells develop antibodies against erythropoietin, leading to destruction of erythropoietin and lead to a syndrome called pure red cell aplasia. Pure red cell aplasia in MRCP exam is related to two scenarios. The first one is exogenous erythropoietin, and the second one is thymoma. Patient with thymoma and anemia, pure red cell aplasia. Patient taking erythropoietin and develop anemia after this. You check ion. Ion is normal. So this is antibodies against erythropoietin, causes isolated anemia. This is pure red cell aplasia. Okay. So this is the treatment of anemia in those patients. Okay, the second complication is related to the calcium metabolism. If we are talking about the calcium metabolism, calcium either is taken orally or synthesized in the skin, then in the liver converted to 25 hydroxycholecalciferol or hydroxycalciferol, in the kidney by the enzyme called 1-alpha hydroxylase. It is converted to 1,25-dihydrocholecalciferol, which is the active form of the vitamin D. Okay, the active form of the vitamin D has many functions. Lead to absorption of calcium and phosphate from the intestine and the kidney, so it will elevate the level of the calcium and phosphate in your body. It will lead to mobilization also sometimes, if needed, mobilization of calcium from the bone. Also, this will lead to hypercalcemia. Those are the major mechanism of the action of vitamin D. Okay, patient with end-stage renal disease, so no active vitamin D, so no calcium, no absorption of calcium. No absorption of calcium, this will lead to hypocalcemia. The kidney is non-functioning and cannot excrete phosphate. So here, hypocalcemia. Kidney is not functioning, cannot excrete phosphate, so hyperphosphatemia. Okay, this hypocalcemia will move and stimulate the parathyroid to release the parathyroid hormone. The parathyroid hormone in response to hypocalcemia will be released and go to the bone, lead to destruction of the bone to mobilize the calcium to maintain the calcium. So this will lead to destruction of bone and form of empty cyst. This is called osteitis fibrosa cystica. And we call it in general renal osteodystrophy. This is how does chronic kidney disease affect the bone, because of the secondary hyperparathyroidism and mobilization of calcium from the bone. Okay, if you are looking to the treatment of the calcium and electrolyte disorder in the kidney disease, the most important thing is to treat the underlying mechanism, which is the vitamin D. So the first line of the treatment in patients with hypocalcemia, hyperparathyroidism, bone disease, to give active vitamin D. We give it active vitamin D. Usually we don't like to give calcium unless severely hypocalcemic, because this will increase the risk of calciphylaxis, which is a known complication of the chronic kidney disease, in which the calcium deposited within the blood vessels lead to arteriolosclerosis and severe vasoconstriction and necrosis of tissues, usually occur on digits. This is called calciphylaxis. So we don't like to give calcium unless indicated. Okay, this is about the calcium. Is treated usually with vitamin D, which will resolve all the problem. Related the phosphate, if the patient has hyperphosphatemia, more than 1.7 millimole, for example, phosphate is toxic. Phosphate itself is lead to mobilization of calcium from the bone. It causes depletion of calcium. Okay, so we have to treat the phosphate to maintain the normal calcium. How to treat the phosphate? We need a drug that binds to phosphate and chelate it, either by deposition in the bone or to chelate it outside. We have two types of drugs of phosphate binders: calcium containing or non-calcium containing. Calcium containing, like calcium carbonate, is useful if the patient has hypocalcemia and hyperphosphatemia. The calcium carbonate will treat the hypocalcemia, also will bind to phosphate and chelate it, and also will treat the hyperphosphatemia. But as we mentioned, that the risk of calciphylaxis, if the patient has normal calcium, don't give calcium. So don't give calcium carbonate for the treatment of the hyperphosphatemia. Give non-calcium binding drugs like sivilamir. Okay, this is used for hyperphosphatemia. So calcium carbonate treat hypocalcemia and hyperphosphatemia. But if the serum calcium is normal, don't go for calcium carbonate because of the risk of the calciphylaxis and constriction of vessels. So go for sivilamir. Okay, this is about the renal bone diseases. The second the third complication is the cardiovascular disease. So aggressively treat hypertension with less than 130/80 target. Give statin for any patient with chronic kidney disease. Okay, other than anemia, other than bone mineral disorders, other than cardiovascular disease, we also have acidosis. Sometimes patients with chronic kidney disease, they have a prolonged acidosis. In this situation, we can give sodium bicarb. Unlikely to see all those stuff in the exam, actually. And I think many of you, they went through the question. This is a complicated question, but I think that is important to know as a physician, okay? So this is the most important complication that should be treated in patient with renal failure. If the patient has overload, give him also diuretics, and usually sometimes they need 2 types of diuretic to respond. Also electrolyte corrections and so on. Electrolyte correction usually is serious in acute. In chronic, usually avoid to give drugs that or combination of drugs that elevate the potassium. If you give them, just monitor the potassium. Thank you very much, Doctor. This is about the management of the complication. If the patient has stage 4 or is going to stage 4, so this patient might need renal replacement therapy. So patient from stage 3, we need to prepare him by vaccination and so on. So this patient might need regular hemodialysis. Renal replacement therapy for stage 4 or 5, we have 2 types. The first is dialysis, and the second is renal transplant. The dialysis, okay, what is the idea of the dialysis? The most important, the dialysis has many corners. This is the patient, okay. The first thing, we need an IV access to draw a blood from the patient. The blood will go to the machine. This is the machine. In the machine, we have the blood on the patient on this side and the dialysate, which is the fluid. Dialysate has no creatinine, has no urea, has no blah, blah, blah. So by diffusion, urea, creatinine, all of the toxic, they will get out into the dialysate, okay? So the blood will return back without urea, creatinine, and a lot of toxin, no toxin, through the filter in the machine. This is the idea of the dialysis, okay? And usually when we are going to start dialysis, many complications we have to think about. There are complications that are related to the vascular access, like thrombosis, like infections, and so on, and complications related to the dialysis itself. If the patient for the first time need dialysis, usually we don't start with the high moods or with full sessions. Usually we start with 2 hours, 3 hours, and then 4 hours. Why? Because we fear from a syndrome called dialysis disequilibrium syndrome. There is a question about this in MRCP. Dialysis disequilibrium scenario of patient, renal failure, receiving dialysis, then the patient become confused. What is the idea? This is dialysis disequilibrium. What is the idea of the dialysis disequilibrium? Urea is osmotic. If you remove, if the patient has a renal failure, this is the brain, this is the brain, huh? This is the vessels within the brain. Patient has many urea. So many urea, so usually the fluid will be situated within the compartment. Most of the fluid will be here. If you suddenly remove the urea, so there is no urea, so there is no osmotic effect on the vasculature. Most of the fluid, they will get out of the vessels. In the brain, this will lead to cerebral edema. And the cerebral edema will lead to this manifestation. This will lead dialysis disequilibrium syndrome. One of the questions in the past is talking about this syndrome. Okay. This is the idea of the dialysis in general. Dialysis, the drawing of the blood is happening or is occurring through a fixed rate. Sometimes patient is hypotensive, very low blood pressure. So they cannot tolerate the machine. They need something called CRRT, continuous renal replacement. This is not for MRCP, just for your information. Continuous renal replacement therapy is a continuous dialysis, might be over 24 hours. And here there is a slow drawing of the blood. This is usually done for patients in the ICU and in the critical situation who need dialysis. In Sudan, we have it, but it is limited in some hospitals, and sometimes we have to look for the benefit of this for the patient. Okay, so this is the idea of the dialysis. The modes of dialysis, we have the conventional. This is the first one. The other is we have peritoneal dialysis. What is the idea of the peritoneal dialysis? This is the abdomen of the patient. This is the peritoneum. We give a device into the abdomen. We connect it to the peritoneum. Then we infuse the dialysate into the peritoneum. Peritoneum will be filled with the dialysate. Also through the diffusion. Okay, the urea, creatinine, toxin, all of them, they will accumulate into the peritoneum. Then the dialysate now has a lot of toxin, then you will draw it back. So you will use your peritoneum as a membrane in spite of the, as a filter, rather than the filter in the machine. The benefit of the peritoneal dialysis, it is easiest. The patient can mobilize, but it is related to many complications, blood glucose issues. It is related to peritonitis. If the patient develops peritonitis, it is usually by Staph aureus. Okay, usually the treatment by intraperitoneal antibiotics is very important to give vancomycin intraperitoneal. This is one of the known complications. If recurrent complication, it might lead to adhesive peritonitis, and the membrane might be no longer functioning for this. Other form of renal replacement therapy is renal transplant. And renal transplant, usually they have a very good survival rate if from leave donor. Usually the concern related to the transplant is the rejection and so on. We will discuss the transplant while we are going through the note. This is the end of the this explanation. The only thing that is remaining is the transplant. I will go through it now from the note directly. Let us start to go through the note, and within 5 to 10 minutes, and then we will go for your questions. Okay, different types. We have conventional, we have peritoneal dialysis, continuous renal replacement therapy. All of them, they are modes of dialysis. Okay, let us go for the notes. This is the idea of the notes that usually we used to in the course, starting by, and this is when we are going, when you are going to study from. There will be an organized note for every chapter, starting by nephron anatomy. This is what we talked about before. This is the anatomy of the kidney, nephron. This is the renin angiotensin aldosterone system, and what we talk about. Yes, something which I didn't talk about, I forget, just a minute. One of the things that I forget to talk about, the other action of angiotensin 2, other than vasoconstriction, it stimulates the aldosterone production. The aldosterone production is very important. Angiotensin 2 is stimulate the aldosterone production. What is the function of the aldosterone? Let me just write. Okay. This is the kidney. The aldosterone will do sodium retention, potassium, and hydrogen excretion. This will lead to more retention of sodium and fluid. This will improve the fluid status, and this is related to many drugs and many diseases that will be discussed later. Okay, this is the action of the aldosterone. It will be discussed later, inshallah, also. This is the aldosterone is released from the zona glomerulosa. This is the structure of the adrenal cortex, zona glomerulosa, fasciculata, and reticularis. Okay, this will be discussed in more details in endocrinology. Zona glomerulosa is the outermost layer, is affected by or influenced by angiotensin 2 and release aldosterone. Fasciculata is influenced by ACTH and release cortisol. Fasciculata reticularis by ACTH and release androgens. Okay, this is the what we already talked about. This is the glomerulus, the afferent, the efferent, and so on. Approach to RFT. This is the AKI. The definition is a rise of creatinine more than 3 or 26 micromole, or more than 50% in the last 7 days, or we can use the urine output. The causes: pre-renal, intrinsic or renal or post-renal causes. Who at risk chronic kidney disease? They might develop acute on chronic. Patient taking drug, history of AKI. Prevention is to prevent patient at risk. Symptoms and signs, how to detect by investigations, mainly how to manage. The management is mainly supportive. If you just go through them, you will find that they are very easy. This is the treatment of the hyperkalemia in AKI, when to refer for nephrologist. Hemolytic uremic syndrome is discussed in hematology. Okay, rhabdomyolysis, this is what we talked about before. They have usually myoglobinuria, also yes, something I forgot. Usually they have hyperkalemia because potassium is intracellular and it will be released from the muscle. This will lead to hyperkalemia. This will lead to hyperphosphatemia, hyperuricemia, but usually they have hypocalcemia because calcium is chelated with myoglobin. So usually in myoglobinuria we find hypocalcemia. High creatinine kinase due to destruction of the muscles. Those are the causes we mentioned about. Usually the treatment is a fluid. If hyperuricemia happens, the treatment is raspuricase. We will talk about this in rheumatology. This is interstitial nephritis and the pathophysiology, the symptoms, eosinophiliuria, chronic kidney diseases. Those are the causes, how to calculate the GFR, and so on. Anemia is the complication and how to manage. Usually the target is 10 to 12. Proteinuria by ACE inhibitors, bone diseases by vitamin D, and treat the hyperphosphatemia. This is the idea. Yes, sometimes patients with renal bone disorder sometimes need parathyroidectomy because the problem is related to secondary hyperparathyroidism, calciphylaxis, as we mentioned. This is the major idea. Okay, so this is the ECG changes of hyperkalemia. The last thing, just let me talk about the last thing is renal transplant. In renal transplant, either we have live related donor or deceased donor. The prognosis is very good with a live related or with a living donor, especially if HALA matched. Okay, the most important issues related is the prolonged use of immunosuppression and the complication. Usually the most important complication is rejection. Okay, the first thing is, what are the complications? We have acute complications related to the surgery, like bleeding, thrombosis, urinary leak. Okay, the second thing that are complications that are delayed, we have acute rejection. Acute rejection happening from the first to the 6th month, and usually is cell mediated and humoral mediated. Chronic rejection more than 6 months. This is why we give the patient usually immunosuppression for a long time. Previously, we use steroid very large doses, but because steroid they are related with many side effects, we used to combine many immunosuppressive drugs. In pharmacology, we'll talk about them, but the idea like this: we give drugs that affect the T cells, like calcineurin inhibitors. We give anti-proliferative. We give steroid. What is the idea of the calcineurin inhibitors? You know, the rejection is mainly mediated by the T cells. Okay. T cells, once activated, will release interleukin-2 to activate other T cells. This is another T cells. Interleukin-2 will work on the receptors. Once activated, it will release interleukin-2 to activate another. This cycle is occurring through the second messenger system, okay, in which calcineurin is an important component. So interaction with the receptors lead to activation of calcineurin bound to DNA, blah, 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 affect the cell, then activate the cell. So calcineurin is an important part of the chain. If you block the calcineurin, you block the chain and you block the activation. We block calcineurin by two types, either by binding with cyclophilin or by binding by FKBP. Tacrolimus is binding through FKBP, tacrolimus, which is the prograph. And cyclosporine is binding to cyclophilin. Both of them inhibit calcineurin and so inhibiting the action of the T cells. So either tacrolimus or calcineurin, both of them, they are nephrotoxic themselves. They are causing diabetes, they are causing hypertension, and so on. But we will give them in a small doses, and usually we monitor the level of the drug because of the side effects. Anti-proliferative usually like mycophenolate. The idea of the anti-proliferative, they prevent the proliferation and the replication of the cells through the inhibition of the DNA. The exact mechanism will be explained later, okay? By inhibiting the DNA, so no replication of the cells, any cells. The active cells in this situation is the immune cells. So you block the activation of the immune cells by this anti-proliferative like mycophenolate, and also we give steroid small doses. This combination will give you a very good combination to prevent. One of the important viruses related to transplant is cytomegalovirus. It's very common to be seen on the exam. Cytomegalovirus is a DNA virus and has a immunomodulator effect. So this might accelerate the process of the rejection. So usually if we transfuse blood, if we even the donor should be CMV negative, and the patient should receive anti-CMV for 6 months after the transplant, like ganciclovir. One of the very important trap in the MRCP, طبعا يعني in infectious I will talk about CMV in details. One of the very important trap is CMV is causing whatever disease. CMV usually in immunocompetent causes mononucleosis like illness, but in immunocompromised causing encephalitis, retinitis, pizza retina, esophagitis, odynophagia, colitis, pneumonitis, and all of them. The treatment of CMV is ganciclovir, is not acyclovir. It's very important. We treat with ganciclovir if the patient is exposed. One of the last note I need to mention, which is not related to MRCP at all, usually if you have young patient with chronic kidney disease and having anemia, try as much as you can to do not transfuse unless indicated. Because if the patient is young, so I think he has a good chance to transplant. If you transfuse the blood, you expose the patient to a lot of exogenous antigen. This will activate the immune system and put them immediately at intermediate risk for rejection. So if the patient is transfused, this will put him at a risk of rejection later on. Okay, they could be they could be transplanted. Okay, no problem, but it's better to avoid unless indicated severe anemia and so on. So this is in a nutshell. Okay, we talk about nephrology overview. This was a basic physiology and approach to RFT, acute and chronic renal failure. In MRCP part 1, they are very direct. They are very nice questions related to acute and chronic renal failure. You might find a detailed question about the glomerulonephritis and so on. Also, after understanding of the lectures and understanding of the topic in a well-established manner, this will be a very good and a very easy job, inshallah. You are welcome to ask any questions you would like, either through message or through the microphones. Regarding the English courses, the Arabic courses usually we did it, and this is the 17th batch is coming, inshallah, within 2 to 3 weeks. The English course will be announced. Anyone who is interested, you can contact me through the group, the WhatsApp group, or even through my WhatsApp number 004 299 192 53033. This is my WhatsApp number. I will write it. We will record the lecture definitely, and we will share it on YouTube, and this will be available for everyone who is going to look for the lecture and the method of teaching. Yes, I wrote the number. Okay. Anyone who is interested, he can contact me. The English course also will be announced later, inshallah, soon. Okay, you are welcome to ask.
Assalamu alaikum, Doctor.
Alaikum assalam wa rahmatullah.
Yeah, thank you for this nice lecture. Just asking about the difference between the I am talking about medical point of practical point of view mainly. Since we are sometimes needing to adjust some medication and some doses, we are confused.
Could you please repeat the question? عيد سؤالك يا دكتورة. خلاص ممكن تتكلم يعني.
طيب. My question, Doctor, regarding the difference between the eGFR and the creatinine clearance. Okay. Because we are in practical point of view, when we are trying to adjust some medication, we are confused which one we are using. The same problem we are facing, when we have like a patient with acute kidney injury, and always we are confused if we need to adjust some medication, which one to use, creatinine clearance or eGFR.
Okay, very good. The first important point is usually patient with acute renal failure, no need for adjustment of the drugs in general. Avoid nephrotoxic. There is a difference between adjustment and nephrotoxic, you know. Nephrotoxic drugs, they are directly toxic to the kidney. Drugs that need adjustment, they are not toxic to the kidney, but if you don't adjust, they are accumulating and they will affect another tissues. Okay. So usually patient with AKI, no need for adjustment usually. Patient with CKD, yes, we adjust. Patient with AKI, we avoid nephrotoxic. Patient with CKD, also we avoid nephrotoxic as much as we can. Okay, regarding the adjustment for the patient with chronic kidney disease, the adjustment usually we can use the GFR or the creatinine clearance. It is the same concept. Creatinine clearance is reflecting the GFR. Just calculate it using your mobile phone. But physiological concept, they are the same. I think it's better to use creatinine clearance because it is the most widely used in the website.
Okay, Doctor. Thank you. Clear. Thank you very much.
Welcome.
Yes, yes, Doctor. Thank you for this presentation. It is really very nice. We got concept and it's helpful for us. Regarding what you said in the beginning, before you refer to all the available resources that we are receiving from as a collection of notes, answers, and they couldn't be reliable for getting the concepts. So what do you advise as the best source that we can get the concept? You have some notes from which we can study to get the
Well,
concept. Thank you.
very interesting. Thank you very much, Dr. Ramzi. Regarding, I think Carla is good, but yeah, sometimes it's out of the point. But this, I think, our course is a chance to relieve this problem. But also, if you need to depend on yourself, you can reorganize the node. You have to reorganize, and if you find long QT, reorganize the node according to the normal usually distribution of the topics. Yani, we all know that in medicine, in cardio, ischemic heart disease, heart failure, valvular heart disease, this is the normal consequence. So reorganize, and if you face any difficulties, go and read about it from YouTube, from any sources, even from other courses. It's better than just read it and rush, because you know that a lot of doctors seeking MRCP, they are under stress to pass the exam. They need just to read as much as they can. Okay, so it's more important than just reading is to understand. So you can go for YouTube, any other reference that might help you.
Assalamu alaikum, Dr. Fadar Rahman. Thank you so much. These lectures are really very knowledgeable and informative. Do you mind if I ask, are these lectures suitable for PLAB exams and for the general practitioner membership exams as well? Thank you.
Alaikum assalam wa rahmatullah. You are welcome, Doctor. Where are you from, Doctor?
I'm a Sudanese. I live in the UK.
MashaAllah. Okay. So we have a different course which is suitable for PLAB, which is step 2 CK and iPhone preparation. It covers all the materials required for step 2 and definitely the PLAB because it is easier. But all those courses are in Arabic. I think إنه قد ما حيكون عندك مشكلة يا دكتور في حتتين انت تفهمها بالعربي او كده، لكن لو هي والله انا I'm planning to do even USMLE courses in English, but it's يعني still not determined.
Thank you. جزاك الله خير.
Okay, you're welcome. If the patient can take it orally, okay. To take it orally. If the patient has severe nausea and vomiting and so on, so he has to take it IV. This is about the iron in chronic kidney disease. Okay, طيب. To not miss this, I don't know, if someone just find the difficulty to find the lectures or to find the whatsoever material, he can just contact me on the number. I will share this lecture inshallah in YouTube and this will be shared. I think there is no more question. Thank you very much. Hope you better future inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.